Good morning. My name is Corey Walker. On behalf of myself and my other authors, I'd like to thank NAS for allowing me to present this research. The title of today's talk is Predictors of Indirect Decompression in Transpsoas Lateral Lumbar Interbody Fusion. Here are my disclosures. When performing lateral interbody fusion, one of the benefits of this surgical technique is indirect decompression of the neural elements. Specifically, this is accomplished by means of realigning the spine, restoring disc height, and resulting ligamentaxis of the disc complex as well as the posterior ligamentous complex, resulting in increase in the central canal and foraminal dimensions. When this occurs, this can result in significant improvements in the amount of space for the nerves, as shown here in this L2 to 5 lateral interbody fusion. However, in a small number of patients, indirect decompression is not as successful and can result in the required need for direct decompression by means of laminectomies or foraminotomies. Multiple studies have tried to predict who will and will not have successful indirect decompression. This is a study out of the Santiago group, which showed that clinical symptoms of resting pain were predictive of the need for direct decompression with lateral interbody fusion. Other authors have looked at attempts at trying to distinguish which patients have radiographic improvement in their indirect decompression at the time of surgery with intraoperative myelography. However, this adds invasiveness and time to the procedure and remains to be clinically validated. Other authors have suggested potential predictive factors for indirect decompression, including bony lateral recess stenosis, as well as the amount of preoperative central stenosis, with patients with more severe central stenosis having larger levels of radiographic indirect decompression. In our study, we sought to identify predictive factors with our large series of 73 consecutively treated patients, resulting in 107 levels treated with a lateral Transpsoas approach by a single surgeon at a single center. This study is unique in that all 73 consecutive patients were treated with an indirect first approach, meaning that no patients received direct decompression unless they presented in follow-up with persistent radicular or central canal stenosis symptoms. The breakdown of the demographic and surgical data of these patients is presented here. All patients received pre- and post-operative MRIs. Post-operative MRIs were obtained within the first 2 days post-operatively while the patient was an inpatient. We saw significant improvements in both categorical ratings of the amount of central stenosis as well as measured amounts of central canal area, which were obtained using three-dimensional volumetric reconstructions of the T2 sequence on the MRIs. We saw approximately 50% improvement in the central canal area across all levels treated. We also saw increased amounts of indirect decompression achieved at lower levels in the lumbar spine, as shown here in C. Associated improvements of anterior and posterior disc height, the amount of listhesis, foraminal dimensions, and segmental lordosis were also witnessed in our study. In our study, we attempted to identify predictive factors for radiographic improvements in the percentage increase in the central canal area. On multivariate analysis, we identified 3 predictive factors. These included lower body mass index, the amount of preoperative posterior disc height collapse or a lower posterior disc height, and the amount of anterior listhesis. All 3 of these were independently predictive of increases in the amount of indirect decompression seen radiographically. However, we also sought to identify which patients would improve clinically, as we felt that this would have the most value in terms of predictive value for a practitioner. When we looked at the amount of improvement in leg pain scores using the visual analog score, we did see a trend towards correlation to the amount of improvement in the central canal area, but this was not statistically significant. This was also not correlated to the amount of improvement in foraminal height, suggesting a complex interplay in symptomatology and the amount of radiographic changes seen on MRI. We did see an increase in the amount of clinical improvement for patients who are treated for spondylolisthesis and adjacent segment disease compared to those patients who are treated with degenerative disc disease alone. We used a minimally clinically important difference as defined by prior studies of lumbar stenosis of a VAS leg delta of 3 to identify those patients in single-level cases who had achieved successful improvement in their clinical symptoms. Of the 32 patients, 25 of these patients did achieve the MCID, with 7 of the patients not achieving the MCID, 2 of which went on to require direct decompression in the follow-up period. Of the patients who did achieve the MCID, the only predictive multivariate variable that was resultant was the anterior disc height. Altogether, these findings suggest to us that the most important variable in patients receiving lateral lumbar interbody fusion in predicting indirect decompression is the amount of disc collapse. Specifically, radiographic improvements were seen mostly with posterior disc height collapse, and anterior disc height collapse was correlated with clinical improvements. Additionally, anterolisthesis and lower BMI may have potential predictive value in determining who may improve radiographically. Further studies will be required to look at these factors and clarify the pathophysiology of these changes. The limitations of this study include that the single-center, single-surgeon study design. Additionally, it is difficult to compare clinical outcomes for central canal area alone, and there is clearly a complex interplay with the foraminal dimensions in patients with radicular symptoms who do not have severe central stenosis, and further research will have to be performed to clearly identify the roles of these different mechanisms. Thank you.